right, welcome to the lecture on the hip and the thigh. This will begin our lower limb portion of the kinetic anatomy course. Some bones here to consider for the hip joint. We have our femur bone, which is the longest bone in our body. For our pelvis, we have three main regions. These three regions actually start out as separate bones at birth, but as we engage in development, these bones eventually fuse together to make up the pelvis. These three regions are the ilium, which is the superior 2/5. We have the pubic bone, which is the anterior 1/5. And we have the ischial bone, which is the posterior 2/5. So all those parts make up our huge pelvic bone. And lastly, here we have our sacral bone. Our sacral bone includes our coccyx, and this is essentially just the extension of our vertebral column. Some important bony landmarks of the femur is outlined on the slide here ahead of you. As I mentioned, the femur is the largest bone in our body, and each of these regions play a particular role as far as important muscle attachment sites for the muscles that move our hip and our upper thigh. For just name a few, we have the head of the femur bone. This articulates with the acetabulum of the pelvic bone. That is essentially that is where the ball and socket articulation occurs. And unlike the shoulder joint, this ball and socket joint is a lot more secure, hence the increased stability that we see at this joint. Along with that articulation, this joint is also reinforced by other ligaments that helps with its stability capabilities. All right, so again, we have the head, we have the neck of our femur. We also have these specific landmarks on the proximal side of our femur bone. We have our greater trochanter. This will be the larger lateral protrusion of bone that we see. The lesser trochanter will be more so on the anterior side. This would be important for small gluteal muscles, especially once we get down into the posterior view. This linea aspera that we see here is incredibly important for our adductor group, which involves with adduction and a little bit of external rotation of our leg. Moving down more distally here, we have our condylar complex, if you will. We have our medial and lateral condylar ridge, medial and lateral epicondyles, and we actually have our medial and lateral condyles. Once we get more distal to our actual knee joint, these condyles will articulate with the condylar surfaces that we see on our tibia, and that will essentially make up our knee joint proper. Again, these landmarks can be seen on the posterior aspect of the femur as well. Again, as I mentioned, this line is incredibly crucial for a lot of our adductor muscle groups. The greater trochanter, the lesser trochanter, and even this intertrochanteric line is important for the major hip extensors. So we're talking glute max, glute med, glute min, those sort of structures. Now, bony landmarks for the pelvis. As mentioned previously, the pelvis bone itself is divided into three different regions, right? We have our ilium, we have our ischium, and we have our pubis region. We're all pretty familiar with the iliac crest, the crest of the ilium. As we move down here, we see our ASIS, our anterior superior iliac spine. We can actually feel this on the anterior aspect of our pelvis. This is the most bony protrusion that we see on the anterior side. The ASIS serves as important origin sites for muscles such as the TFL, our tensor fasciae latae, also our sartorius muscle as well, which is actually the longest muscle in our body. Moving down here, we have our anterior inferior iliac spine. Now, this particular bony landmark is critical only because that this is where our rectus femoris originates. Our rectus femoris is one out of the four muscles that make up the quadriceps group. So our quadriceps consists of our rectus femoris and our vastus group. Vastus group meaning our vastus lateralis, medialis, and intermedius. Now, of that quadriceps group, the rectus femoris will originate on the anterior inferior iliac spine. And this is important because this is the only quadriceps muscle that attaches to this site. What this means is for hip flexion, the only muscle out of the quadriceps group that aids in hip flexion will actually be the rectus femoris directly. Moving down to our pubic region, we have our pubic tubercle. We also have, the ramus of our pubis, the body of our pubic bone. These bony landmarks will serve as important attachment sites for small adductor muscles that will act to aid in hip adduction. And we'll also see actually some of our anterior compartment muscle groups of the thigh that also originate in this area. So moving on the posterior side, the ischium is the bony region that is on the posterior aspect of the pelvis bone. And one of the more prominent bony landmarks in this region here to consider is the ischial tuberosity. Here is named the tuberosity of the ischium. This is where our hamstrings originate. Our hamstrings will consist of three main muscles. It will be our biceps femoris, our semitendinosus, and our semimembranosus, right? Also, this huge hole here that we see here is the obturator foramen. We'll have our small obturator muscles here, a kind of transverse of this foramen. We will also have various neurovasculature pass through this area as well. Moving on to the specific joint sites that are located here at the hip region. We, of course, have our ball and socket joint. Officially, this is called the acetabulo-femoral joint. And we will also talk about our SI joint, our sacroiliac joints. Again, this will be found on the posterior aspect of our pelvis. And you'll notice here that both of these joints will serve as critical structures, especially during ambulation. So our acetabulo-femoral joint, this is the articulation between the head of the femur and the acetabulum of our three hip bones. What's interesting here, if I'm able to move up, the acetabulum is actually made up of each of those, of a small piece of each of those specific regions that make up the pelvis. Anyway, this is a synovial ball and socket joint. Among all the joint structures that we covered, this is probably one of the more, if not the most stable joint. And its stability is mainly due to its bony architecture, strong ligament support, as well as the large supportive muscles that surround the joint and that surround the joint as a whole. Its stability is warranted, obviously, because the hip joint functions in our ability to weight bear, especially during locomotion. This is a triaxial joint. So we have movements about 3 planes of motion. So we're able to engage in hip flexion, hip extension, hip adduction, abduction, as well as hip internal and external rotation. As far as the strong ligamentous support that we see about this region, we'll talk about 3 main ones. And just like as we see here in the shoulder, the stability is further enhanced by the labrum. So the labrum will be located right on the acetabulum, and it serves to increase that cross-sectional area to allow the fit to be more secure and snug, right? Again, our labrum is made of that dense fibrous cartilage tissue. Here we have images depicting the acetabulo-femoral joint. and I've identified the three main ligaments of note. If you notice here in the name, the ligaments are the iliofemoral ligament, the pubofemoral ligament, and the ischiofemoral ligament. By the name, you know that each of these ligaments will connect each of these specific regions of the pelvis to the actual femoral bone. You also notice that the insertion points of these ligaments are on that intertrochanteric line of the femur bone. Our iliofemoral ligament actually prevents the hyperextension of our acetabular-femoral joint. Our pubofemoral, as well as our ischiofemoral ligament, also serves to reinforce the hip joint capsule as a whole. The pubofemoral joint can be seen more so on the anterior side, and it prevents excessive abduction, lateral rotation, and extension. And on the posterior side, our ischiofemoral ligament will essentially limit medial rotation of the acetabular-femoral joint. Another important note, along with the various structures of the actual joint, we also have this small foveal ligament here, also known as the ligamentum teres, and it actually adds as another connective mechanism which attaches the femoral head to that acetabulum. Our next joint here will be our sacroiliac joint, also known as our SI joint. Same thing with our anterior superior iliac spine. You can also kind of palpate the posterior superior iliac spine. It will be that bony protrusion on both sides there of your lower back. And this would be the articulation between the sacrum and the ilium bone. Again, this is a synovial joint, and this joint is actually really reinforced by strong various ligaments. We won't get into the specific ligaments here for the sacroiliac joint. Just want you all to note that this joint is especially important for transferring load, absorbing shock. This is especially while we move, jump, run, etc. Our ability to dissipate our forces mainly actually occurs here at the SI joint. And because of its responsibilities to act as a stabilizing mechanism and as a mechanism to transfer our load-bearing actions and activities, it is limited in its motion functions. Here's another image here depicting the specific joint regions of the SI joint. Again, it will mainly attach between the regions associated with the posterior iliac spine, articulating here with the superior lateral aspects of our sacral bone. Another articulation here to consider, this is actually not a synovial joint, but it is an important structure about this region nevertheless, and this will be our pubic symphysis. So of course, when we talk about these regions, we are talking about them in a bilateral sense, meaning that we have two pelvic bones articulating with the pubic symphysis. This is a non-synovial fibrocartilage joint. However, it is covered by hairline cartilage. It's important here because, again, with our anterior anchoring point, which holds these bones together, on the posterior side, you'll notice that we have our sacroiliac joint. Again, compared to the pubic symphysis, you can kind of get a better picture of why the dispersion of force, especially when we walk and when we move around, is mainly handled by the SI joint, just due to the larger cross-sectional area of these particular joint sites. However, on the anterior side, the main thing that is holding the right and left pubic bones together will be the pubic symphysis. So when we get into our muscle groups, some of our anterior as well as our medial muscles will actually attach right on the pubic symphysis. A quick review over the movements that we see about the hip. Again, this is a triaxial joint articulation. So we have movements about 3 planes. We have hip flexion and hip extension, hip abduction and hip adduction. And lastly, we have hip internal and hip external rotation. All right, that hip external rotation will also be called as hip lateral rotation, and hip internal rotation may also be called hip medial rotation. Okay, now for the muscles of the hip. Now, as you see, there is a lot of muscles that act on the hip. And of course, if we're dealing in a realistic sense, all of these muscles play various muscle action roles as far as specific hip movements are concerned. So what I have done here is I have divided each of the muscles that we see in this joint region into various compartments. These compartments are based off of where they are found in respect to the thigh and anatomical position. And how I am presenting this is based off a consolidation of references. You may see in other anatomical textbooks that how they divide these hip muscles may be a little different. The overarching picture as far as where to group these hip muscles are articulated in the screen here in front of you. So for the muscles in the anterior compartment, these are the muscles that are primarily responsible in hip flexion. For the posterior compartment, these are the muscles that are found on the posterior aspect of our hip. These muscles will be primarily responsible for hip extension. For the medial compartment, these muscles are primarily responsible for hip adduction. So bringing your thigh closest to, or your leg closest to the midline of your body. And we have our lateral compartment, which is primarily responsible for hip abduction. You notice here that for simplistic purposes and just to help you organize their primary responsibility as far as hip movement is concerned, wherever they are located will give you a sense of what they actually do about the hip joint. You notice here that internal and external rotation is a little more nuanced, but however, a good starting point here is to kind of organize the muscles that I'm about to speak on in these components, so you guys have a nice starting foundation of what they do. Starting off on the anterior side, our anterior muscles of the hip will be our iliopsoas, our sartorius, and our rectus femoris muscle. These muscles will be mainly responsible for flexing at the hip. Now, the iliopsoas, this is actually a combination of 3 different muscles. The term iliopsoas is used once each of these muscles cross the hip joint and they attach on the lesser trochanter of the proximal femur. So this portion right here is actually what we will be referring to when we talk about the iliopsoas muscle. But the iliopsoas is made of the iliacus, which is found on the iliac fossa, or the ilium fossa. And we also have our psoas major and our minor muscles, which originate on the lumbar aspect of our vertebral columns. So for the actual iliopsoas, the muscle fibers that would transverse the hip joint right underneath the inguinal ligament here will be the fibers of the iliacus, as well as the fibers of the psoas major muscle. Those muscles will cross the hip joint and will attach at the lesser trochanter. The sole responsibility is to flex the hip. If you hear a lot of individuals say like, man, I have tight hip flexors, they're mainly referring to this muscle group here, the iliopsoas. Another anterior muscle we have here is the sartorius muscle. The sartorius muscle is actually the longest muscle in our body. If you all remember, longer muscles are advantageous for speed and range of motion actions. our ability to flex our leg at a higher velocity over a greater distance is due in part primarily to the sartorius muscle. So actions such as running, quick movements, etc., that we see about the hip joint, the sartorius plays a huge role. It is also rather versatile. Not only do the actions of the sartorius include hip flexion, it's also prevalent in hip external rotation as well as hip adduction. So I think about when you sit in a butterfly pose, that butterfly pose, how your upper thigh and your hip is oriented is directly engaging the sartorius muscle. And our last major muscle that we're talking about on the anterior compartment would be the rectus femoris, right? So our rectus femoris crosses the hip joint, and it actually originates on the anterior inferior iliac spine, and it attaches along with the rest of the quadriceps muscles to the tibial tuberosity via the patella ligament. The rectus femoris is one of the four muscles that make up the quadriceps groups. However, this muscle is the only muscle in the quadriceps group that acts not only on the knee, but also on the hip as well. Moving on to the posterior compartment muscles of the hip. These are the muscles that are responsible primarily for hip extension. We have our gluteus maximus muscle. This muscle actually originates on parts of the ilium as well as the sacrum bone, and it attaches on the IT tract. This IT tract is also an extension of our TFL muscle. And of course, by its size, it serves as a major hip extensor. Another major group that extends the hip will be our hamstring muscles. Our hamstring muscles are comprised of our semitendinosus, our semimembranosus, and our biceps femoris muscles. You notice that each of the hamstring muscles originate on and around the ischial tuberosity. But as you move more distally, you notice that our semimembranosus and our semitendinosus will attach more on the medial aspect of our tibia, and our biceps femoris will attach more so on the lateral aspect of our tibia. So along with the conjoined function of the hamstrings to extend the knee, our semimembranosus and our semitendinosus muscle will also have that hip internal rotation action, while the biceps femoris will have that hip external rotation. I think I mentioned the biceps femoris will attach on the lateral aspect of the tibia. That's not completely incorrect, but the main attachment site here that we'll see will actually be the head of our fibula bone. But either way, just know that that is on the lateral aspect. So along with hip extension, our biceps femoris muscle specifically will also have that hip external rotation action as well. And lastly, we have these group of muscles that are deep to our gluteus muscle group. And we're not going to get into the specifics of each of these muscles. Just know that they essentially work together to help not only extend the hip, but also externally rotate. This piriformis muscle is actually a landmark muscle. The huge sciatic nerve runs beneath the piriformis muscle. The muscles down on the medial compartment of our hip will be our adductor group. The adductor group, along with the gracilis and the pectineus, will primarily adduct the hip. If you look here to a more superficial aspect here, we see our gracilis, and you see our pectineus and our adductor longus. The huge portion of the adduction actions will be primarily through the adductor magnus muscles. Either way, just know that all these muscles essentially work together to adduct the hip. It's also an important note that a majority of these muscles also aid in hip flexion, almost as an stabilizing mechanism in order for us to engage in hip hip flexion. Lastly, our lateral muscles of the hip. These would be muscles primarily responsible for hip abduction. We have our gluteus medius, our gluteus minimus, and our tensor fasciae latae, our TFL muscle. Our gluteus medius muscle is incredibly important for hip stabilization. This muscle is probably the most crucial as far as stabilizing at the hip. Other muscles that also have this hip abduction action, we mentioned our sartorius earlier. Our piriformis muscle, also when contracted, abducts our hip. And we also have our superior fibers of our gluteus maximus. Interestingly enough, the inferior fibers of our gluteus maximus will serve to adduct the hip. Again, as far as testable materials are concerned, just focus on these three muscles that are bolded, and just kind of know that these muscles are also active in abducting the hip as well. Now, for muscles that internally rotate the hip, we have our anterior fibers of our gluteus minimus and our gluteus medius. So by anterior fibers, these are fibers that are located more so on the anterior side. Conversely, you know that for hip external rotation, we will have the posterior fibers of the gluteus maximus and the medius. However, for hip internal rotators, along with those muscles, we have our TFL muscle, and we also have our semitendinosus and our semimembranosus. Again, please note that the internal rotation action from the semitendinosus and the semimembranosus comes from the fact that these muscles will attach more so on the medial side of the tibia. So when they contract, not only do they extend at the hip, they'll also cause the upper thigh to internally rotate. For our hip external rotation, it will essentially be our gluteal muscle group, more specifically for the gluteus medius and the gluteus minimus group. This would be our posterior fibers. So these are the fibers that are located more so on the posterior aspect, right? Along with our main gluteus group, we also have our deep gluteal muscles that are responsible for external rotation about the hip. I also put down here, obviously, sartorius, the adductor muscle group, and the long head of the biceps femoris will also aid in that hip external rotation action. For the long head of the biceps femoris, this is mainly due to its insertion point on the head of the fibular bone, which is located on the lateral aspect of your lower leg. The adductor muscle group, now this is important because of course the adductor muscle group is found on the medial side. So you would think that along with adduction of the hip, it would also engage in internal rotation. But to the contrary, the adductor muscle group, when contracted, will actually externally rotate the hip. And this is mainly because their insertion point is on the medial aspect of the linea aspera, which is found on the posterior aspect of the femur bone. So you notice, due to that particular attachment, once they contract, they pull the posterior aspect of your femur bone more medially, which causes the leg as a whole to actually externally rotate. So again, contrary to common belief, the adductor muscle group, when contracted, will also cause your hip to externally rotate. A little bit of irrigation. I want you all to really pay attention to the more superficial blood flow here on the left leg of the particular image. The main blood supply for all of the muscles here that we're mainly talking about will be the femoral artery. Femoral artery is essentially a continuation from the external iliac, and the external iliac comes from the common iliac, which comes from the abdominal aorta. For the purpose of this class, just primarily know that for the blood supply that is supplying the muscles and the structures of the hip And the upper thigh muscle, it will primarily be branches coming off the femoral artery. It's also interesting, once we go into the knee lecture, you notice that the blood supply is coming from the same vessel. It just changes its name once it reaches the knee joint. And the new name of this vessel will be the popliteal, and that will primarily be responsible for blood supply at and around the specific knee joint. And I have another image here just kind of depicting that. The specific area in which the artery changes its name, it actually crosses this canal from the adductor magnus muscle, and it's called the adductor hiatus. If I can go up, perfect. So from the adductor magnus muscle, kind of have this space here. This space is called the adductor hiatus. So what would happen is you'll see you have your femoral artery. Let's see if I have a pen, right? So we kind of have this femoral arteries kind of, coming down here on the anterior side. And then it actually kind of loops around this area, and it goes between the fibers of the adductor magnus muscle. It's essentially the same vessel, but for naming purposes, this would be the femoral artery. And then once it passes out of the adductor hiatus, it is now called the popliteal artery. Probably TMI for the purpose of this course, but either way, just to give you all a nice introduction for things to come in your educational future. Now for the nerves, I'm gonna keep it very simple. On the anterior aspect, the nerve that is responsible for innervating a lot of the features on the anterior hip will be the femoral nerve. Very easy to remember. For the medial compartment muscles of our leg, it will be a combination between the femoral nerve and the obturator nerve. The obturator nerve, comes out of that obturator foramen, and it would actually innervate most of the muscles on the medial aspect of your upper thigh. Now moving on to the posterior aspect, one main nerve of note that I want you all to consider is this huge nerve called the sciatic nerve. Remember earlier on in the lecture that the landmark muscle here is our piriformis muscle. So our sciatic will actually run underneath our piriformis muscle. And some individuals, the sciatic nerve will actually pierce the piriformis muscle. So when we talk about piriformis syndrome, kind of have that neuropathy on the posterior aspect of your leg. And by neuropathy, I simply mean just characteristics involving numbness, a tingling sensation, pain, etc., that is caused from the irritation of this sciatic nerve. So if that piriformis muscle is tight in any way, it may compress that nerve, and it may cause a neuropathy or symptoms down the leg. As we move down, the sciatic nerve actually branches into two separate nerves. These two separate nerves are the tibial nerve and the common peroneal nerve. The common peroneal nerve is also known as the common fibular nerve, and it's called common because it will bifurcate again into your deep and your superficial peroneal nerve. For the purpose of this class, I just want you all to know that there's a huge nerve that goes down the leg that's called the sciatic, and it branches off into your tibial and your common fibular or common peroneal nerve. And I kind of touched on this on the previous slide. The sciatic in most individuals will actually run underneath the piriformis muscle. However, in about 15 to 20% of the population, parts of the sciatic nerve are actually run in between, essentially piercing the piriformis muscle. What occurs here is they may have a higher chance of developing piriformis syndrome. The next few slides will serve as clinical correlations for you guys to consider. One of the first, movement patterns that we see about this joint region is what we call pelvic tilt. The most common ones that you'll hear is the anterior posterior pelvic tilt. Your pelvis is oriented will automatically implicate how these muscles pull and interact with your body. This is incredibly important because, again, a lot of muscles, joints, bones that are crucial in providing our overall body and core stability is in this region. So you want to make sure that's oriented in a way that allows its structures to do its job more efficiently. Another clinical correlation here to consider is what we call a valgus collapse. And we actually see it more so in the knee, but you can also see this kind of, caving inward on the upper thigh portion of our leg. And this is primarily responsible due to weak hip adductors. Again, what's incredibly important here when we talk about hip adductors will be that glute med muscle. That glute med muscle is one of our huge hip stabilizer muscles. So our inability to maintain that hip adduction action will cause that upper thigh to essentially sink in, especially when you're trying to load up, when you try to squat, etc. And because of this valgus collapse, there is, of course, an increased risk for an ACL injury. There's also a decreased ability to transfer force, because as we engage in forceful movements, we really rely on our body's mechanism to dissipate forces in areas that shouldn't be subjected to higher force loads. Again, this is incredibly common. And although this can be due to tight or strong adductors, it's primarily responsible due to weak hip adductors. The best way to assess whether you have some sort of degree of valgus collapse is assessing yourself while you squat, while you jump, while you land, and see if you have that caving inward of that upper thigh. And if you do, one of the first areas you should look for to mitigate the issue is to address your hip adductors, primarily glute med muscles, and also looking to loosen up the anterior and medial compartment muscles. What you'll also see in individuals that have weak hip adductors is the Trendelenburg gait. And this gait is usually characterized as the contralateral hip dips to transfer force. It's doing that because the weak musculature is unable to support their own weight. I mentioned this time and time again, the gluteus medius muscle is a huge hip stabilizer. And unfortunately, it's one of the first muscles that are also prone to be underactive, especially while we sit down too long or engage in sedentary movements. If we see a common theme here, a lot of the clinical cases here are due to our overactive hip flexors and other muscles on the anterior aspect of our hip joint region, and the weakness on the posterior side. So obviously, to address this, we would need to strengthen the musculature on the posterior aspect of our hip, as well as work to loosen up, essentially calm down the muscles that are being overactive in the case. And that is the end of the lecture. I know I touched on aspects of the knee. Don't worry, this will make more sense as we move down the joint region. I'm just trying to give you an overall picture of what to expect, so that way, once you all watch the knee lecture and the ankle lecture, you can begin to kind of connect particular muscles that act on more than one joint region, and begin to connect the dots, and kind of begin to look at this as more of a holistic point of view and not just particular joints.